Welcome to Robert Wood Johnson University Hospital's Somerset Health Talk. I am Dr. Douglas Ashinsky of Robert Wood Johnson Physician Enterprises, Warren Internal Medicine. Maintaining a healthy weight is key to overall good health, but it's not always easy. About 27% of New Jerseyans are considered obese, and the numbers are on the rise. For those struggling to lose weight through diet and exercise, weight loss surgery may be an option. On today's show, we will learn more about weight loss surgery from Dr. David Ward, a bariatric surgeon with Robert Wood Johnson Physicians Enterprises, Somerset Bariatric and Metabolic Center, and Sandra Calado, a registered nurse who's the bariatric surgery coordinator at Robert Wood Johnson University Hospital, Somerset. Welcome to the show. Welcome, both of you, and thank you for coming to talk to us all about weight loss surgery. We're going to first start with Dr. Ward. Tell us a little bit about your background and, again, where your practice is so people can learn some information.
I've been practicing in New Jersey for 20 years, doing weight loss surgery and general surgery. The majority of my patients come from Morris, Somerset, Middlesex counties, but we've been drawing patients from across New Jersey into our hospitals in the Barnabas system. The major surgeries that we've been performing over really the last 10 years are gastric sleeve surgeries. Before that, we used to do a lot of gastric bypass surgeries, but now the vast majority have been gastric sleeve surgeries.
And you are a general surgeon, basically, who specializes in bariatric surgery.
Correct. 20 years ago, there was no fellowship for minimally invasive bariatric surgery, so we taught ourselves 20 years ago. Now there's special residencies that train the residents in bariatric surgery, but with 20 years experience, I'm lucky enough they let me do it still.
And your office is located?
In Bridgewater, 1200 East Route 22.
And Sandra, tell us a little bit about yourself and what got you interested in being a coordinator at the practice.
I have been a registered nurse for the past 19 years. The past 9 of them, my focus has been on general surgery and bariatric surgery. I recently finished my master's degree 2 years ago, and most of my work there was in weight loss surgery, weight loss, things of that.
First of all, congratulations on 19 years, and then also congratulations on getting your master's degree in it.
Thank you.
Now, weight loss. In the United States, as we've previously talked, everyone, unfortunately, is getting a little bit bigger. In a primary care office, we measure people's weight usually by what's called a BMI, a basal metabolic index. Do you want to tell us a little bit about what a basal metabolic index means?
Well, everybody's either tall, short, wide, thin. So you have to have some metric where you make everybody sort of the same standard. So a tall person who's 250 pounds is different than a person who's short. So the BMI gives us a sense of how heavy you are based on your height and weight. It's not a perfect thing because obviously a person who's very muscle dense, their BMI will be a little different than a person who's not, but it's some marker that we have to start with to consider whether people are obese, overweight, are they candidates for surgery, should they just be seeing the doctor, for a diet, should they be on medications. So that's the marker we sort of use this to start with, and then off of that marker, the insurance companies, ourselves, the doctors will start determining treatment plans.
So as I said, in our primary care office, we look at the BMI, and again, if the BMI is 25 or less, we consider them pretty normal. Between 25 and 28, they're slightly overweight. 28 to 30, they're larger, and above 30, we start to call them obese. We're really not sending that person at 30 initially to you for the bariatric surgery. We're trying to control them with diet, exercise, weight loss. The problem is they also develop other metabolic illnesses, metabolic syndrome, diabetes, hypertension, increase, heart disease. So when there is those type of things plus an elevated BMI, I send them to you for an evaluation. And usually the first person I talk to is the nurse coordinator. Now, do you want to tell us your role there?
My role at the hospital, primarily with respect to the patients, I serve pretty much as a liaison between the staff members, the surgeons, and the patients. So I do a lot of education with the patients. I meet with them prior to the surgery. I let them know what they're going to expect. When they present on the day of their surgery, I let them know what they're going to expect when they reach their room that day, and their post-op day 1, which is the following day. So I do all of that education with them. I make myself available to them at all times so they know that if anything is going on, if they need a quick answer, if they need anything, I can be in their room in a matter of minutes because I'm in the hospital all day.
Again, it's a whole process. It's not something that's thought up in one day and we go into the OR the next day. It starts with education. It starts with, basically having the person go through a medical evaluation whether or not they are a candidate for surgery. And as you had talked previously, we've really revolutionized surgery. Initially, we had the RWJBarnabas procedure where we did the bypass, and people were in the hospital for a prolonged period of time. And they did well, but it was a prolonged surgery. Do you want to tell us about, again, you want to go through the evolution of what we're doing in bariatric surgery previously and what we're doing currently?
Sure. If you go back into the 70s and 80s, people had open surgery. So it was mostly gastric bypass, or what they called vertical banded gastroplasties, where they made your stomach smaller, put like a little silastic band around your stomach, but you had a big incision. And when you can consider when you're a big person, big incisions, a lot of wound infections, complications. So once in the late 90s, we started doing minimally invasive surgery with small incisions. The number of people who would be willing to undergo surgery really increased, and the type of surgeries that we started doing changed. So in around 2000, gastric bypass, like the Roux-en-Y gastric bypass, was very popular. Then the lap band got approved in 2001 by the FDA, and that became popular because it was less invasive. More people wanted to have that surgery. That became really grew rapidly in the mid-2000s. And then, like all things have issues. There's nothing without complications. So lap band surgery had some issues with weight loss. People didn't lose as much weight as they want. And then they were finding out through a procedure called laparoscopic gastric sleeve that very large people who weren't candidates for banding or Roux-en-Y surgery were having these laparoscopic gastric sleeves to lose weight even before another procedure. And they lost a significant amount of weight. So then they did trials and they looked comparing gastric sleeves to Roux-en-Y surgery, and they found out that people did pretty close to Roux-en-Y surgery with less complications, less long-term issues. And then that got approved by the Medicare and the insurance companies, and that became what is now like the most popular procedure, where a portion of your stomach's removed. We don't like redo the plumbing like we do with Roux-en-Y gastric bypass surgery, and now patients have less upfront complications, meaning the risks of complications are lower, and the outcomes are pretty similar with less long-term complications, so the patients are much happier with that surgery.
So again, we went from open type of procedure where the person, again, used to come into the hospital the day beforehand, be pre-op, have the surgery in the hospital, usually for about 5 to 7 days afterwards because it was open. Now to something that's laparoscopically, basically through the abdominal wall, and they're home. When do they go home?
So patients with lap band surgery were going home the same day. People with sleeve surgery go home the next day. And they usually have 5 little incisions, usually say 3 or 4 the width of a pencil, and the other ones maybe 3 pencils width, so width of a quarter.
And you're doing these procedures at Robert Wood Johnson Somerset Hospital?
Correct.
Okay. Who are the candidates that you feel is appropriate for weight loss surgery?
So we sort of define it into different categories. First, we look at age. So anybody from 18 up. We've done people up to 82 who need to have hip replacements, and they're too heavy to have the hip replacement by the orthopedic surgeon, and they're otherwise healthy, 82-year-old, and they have surgery and lose the weight and get their hips replaced. Then we look at candidates. Obviously, you were talking about BMI. So if your BMI is 30 to 39 and you have other health issues, type 2 diabetes, heart disease, severe osteoarthritis, sleep apnea, then you're a candidate. The insurance companies will allow you to have that surgery and pay for it. If your body mass index is 40 or greater, then you don't have to have those comorbidities. You qualify for surgery.
As you just said, the people who have the BMI between 30 and 39 who have the comorbidities, there was just a recent New England Journal of Medicine article on the people who have those BMIs and have diabetes, showing that their diabetes suddenly become under well controlled and their high blood pressure well controlled, thus reducing their comorbidities and problems with complications later on in life.
Correct. The key when you compare medically managed weight loss in patients whose BMI is over 35, comparing to surgical weight loss is dramatic. So if you took 100 people and you say those 100 people 100 pounds overweight, and you split them into two groups, 50 people get medical management and the other 50 get surgical management, only one person in the medically managed weight loss 5 years later will have lost enough weight, we say like 50% of their excess body weight, whereas 75% of the people, so about 35 people in out of the other 50 will have lost more than, let's say, 50 pounds, which is drastic. I mean, you think about like losing 50 pounds as a medical doctor, you know, a lot of times their hypertension either gone or controlled better. They're off more medications. Type 2 diabetes can resolve. So either they're off insulin or they're on less medications with better, what they call hemoglobin A1C, that shows how their sugars are being controlled. So there's a big difference in that patient population between medical treatment and surgery.
As I've seen in my office, most of my people who've gone through the surgeries that you're talking about have been able to actually eliminate almost all of their medications. And the people who were diabetics, even on insulin or 3 or 4 medications, have either gone to almost no medications or possibly just 1 or 2 medications with a much better controlled diabetes, much better controlled high blood pressure, and reduced risk of heart disease down the road.
So also it's important, is like you mentioned very beginning, that it's not a simple process. So the patients have to go through a preoperative evaluation and also see a nutritionist depending on their insurance, how many times, maybe up to half a year with the nutritionist. And what's very interesting is the people who do better before the surgery do better after the surgery. So patients who lose weight during the preoperative process with the nutritionist tend to have better outcomes long term, because I always say the surgery is half the game. The other half the game is the patient following the rules. And if you don't follow the rules, even after surgery, you won't be as successful. So that's where like Sandra comes in important in like helping the patients understand the diet afterwards, follow up. And in our office, we have a nutritionist that's in the office all the time. And every appointment, even after the surgery, they see the nutritionist as part of the visit to go over what they're doing, how they're eating, to help maintain their weight long term. Because it's not enough just to have the surgery and then 2 years you do well, and then the next rest of your life you're not doing so well. It's a big investment from a risk standpoint, from the monetary standpoint, so you really want to have good outcomes.
So again, it's the whole team at the office that's involved in it, and it's usually anywhere from 4 to 6 months prior to surgery. It's involvement of the nutritionist. It's involvement, if the person has heart disease, the cardiologist. If the person has any sleep apnea, it's involvement of the pulmonary person for sleep apnea. And many people also psychologically, to make sure that they actually understand what is going on prior to and afterwards, because they are going to be a different person afterwards. Because afterwards, they're going to have, now, the diet afterwards. That's what a lot of people are going to ask you about. What do you do afterwards?
So the initial, let's say, week to 2 weeks, they're usually on a liquid to puree diet, and that progresses how they're doing. And then after about 2 weeks, they go on what I call a regular diet, but it's more high protein, low carb, better food choices, and that's where the nutritionist comes in, working with each person individually. Because I've found that if you force people to eat certain foods that they don't like, they're not going to eat those foods long term. They're going to go off and start going back to bad foods. So we try to individualize the diet after 2 to 3 weeks to the foods people like, but making better choices. A common thing we do is try to have people meal prep on a Sunday for their entire week, so they take away the stress. If they have children, they're trying to make meals for the family. If the husband has a job that has different hours, if you don't prepare your meals ahead of time, the odds of success are low. So we give a good amount of time to teaching people how to like weigh their foods, meal prep, understand how many calories they're getting, how much protein they're getting. So it's an education long term. So once they're not following up as often, they still understand how to manage their nutrition.
So Sandra, you want to tell us a little bit? I send someone to your office. What's the process exactly from start to finish?
So again, when the patients are coming in, I'm meeting them pre-operatively, and again, I discuss with them what the procedure is, what
But even before the
expectations are.
The 6 months, you want to talk about what happens for the 6 months?
The 6 months is generally a process where the patients are coming in, they're meeting their surgeon initially for a consultation where the procedures are explained, what the expectations are, and again, meeting with the nutritionist. And that would depend also, like Dr. Ward said, on what the criteria is of that particular person's insurance company. It could be 4 months, it could be 6 months, and every insurance company requires a psychological evaluation. And as you said, to see where the person is in terms of, can they manage this? Are they prepared for this? It's not just understanding what it is, but it's also being able to manage it in the long term. What their support systems are, and things like that.
Now, when someone comes to your office and they say, okay, I want this type of a surgery, how do you and the patient come to terms with the right type of surgery for them?
So times have changed, and the internet's a big factor. So I'd say 75 to sometimes now maybe 90% of people have done a lot of research on their own through their primary care doctor, on the internet, and they come pretty much with their mind made up. And it's pretty hard to change it if I don't agree with them. But we go over all the options with each patient, the risks, the benefits of each procedure so that they're well informed. Like I say, today most people come in with the idea of having gastric sleeve. If I don't think that's the best choice, I would discuss it with them. As per each plan, there's also some plans based on your weight, they sort of won't let you have the lap band anymore because the outcomes aren't as good. So there is some insurance pressure on what patients can have. But most people today are pretty savvy. They've gone on the internet, done research. They go to seminars, maybe multiple seminars ahead of time, get information. The good thing with Sandy, like Sandy's involved in our program at the hospital, and that's really important. I always say there's like 3 phases to the surgery. There's the pre-phase where the patient's seeing me, they're seeing nutritionists, the phase of the hospital, and the after phase. If the hospital's not successful, then the next phase is successful. So Sandy's really important at the hospital, connecting with the patients, making sure that the nursing staff knows what the patients need, making sure that if there's any issues after the surgery, it's dealt with quickly so there's less complications long-term, less complications in the hospital, making the patients feel at ease, meaning that there's a connection. They're not, it's rare that at most hospitals they have a coordinator that's right on the floor with the patients. That's great at Robert Wood. And then the transition from the hospital afterwards, making sure they're on the right medications, because medications do change. Like if someone's diabetic and they're taking a lot of diabetic medications, now they're not eating enough, you have to really make sure the sugars are managed well. They don't have low sugar, too high sugar, not taking enough medication. So Sandy's involved in that and communicates with myself, as well as they can communicate with the primary care doctor to make sure that all the medications when the patient goes home are as well understood, so patients don't have that level of stress of what medications they'll be taking.
So the patient's ready for coming into the hospital. Tell us about that day at the hospital.
On the day of the surgery, the patients are coming in. They're coming in through the same-day surgery unit. They are being prepared for their surgery then. They'll go in to the OR. They have their procedure. Once their procedure is completed, they then go to the recovery room where they spend a fair amount of time there, where they're closely monitored by the nursing staff there. Once they have been determined to be safe, that it's a safe discharge from the recovery room, they then go to our floor where they do their post-op recovery. All of our nurses there have been bariatric certified trained. So each nurse that's taking care of our patients has gone through a education process where they have this knowledge base where they're able to deliver safe and good care.
Well, the important thing is the fact that, one, you're there on the floor with them. Mm-hmm. So if there's any questions, problems, et cetera, you're there, immediate access. Number two is the fact that the nursing staff there is bariatric certified, that we're not just taking people off the floor, moving them over there and saying, okay, follow them up. They know the possible complications. They know what to be looking for. And at the same time, we have this terrific bariatric surgeon who's done a good job with them, then comes back, checks to make sure that everything is proceeding accordingly. Mm-hmm. Now the person is discharged. At the time of discharge, what are they being told?
At the time of discharge, we're going over what their activity should be. If there are any lifting restrictions and what those are, we're going over diet, we're going over support, because that's really important, making sure that they know when they're supposed to be following up with their surgeon. encouraging them to come back and attend support groups, which we do hold monthly at the hospital. We do encourage that because we want patients to stay motivated and stay on track and you know, be on board after they've had this procedure done so that they can continue to be successful with their weight loss and their health.
What the people have to realize is that even though it's done laparoscopically, it still is major surgery. And it is going to change their life. And as you had said prior to the surgery, they were all going to have a psychologic analysis done to ensure that they do understand that. Because post-operatively, if they want to be successful, they have to follow through with everything that what you're telling them about. Plus, as you said, the support groups are so important afterwards, because it's very easy a year or two later, if they don't follow through, for them to gain weight back rather than continue to maintain the low weight loss. Now, you've had lots of patients come through, and most people are extremely happy about it. Tell us anything, successes, what you see the future of this to be.
So, like I discussed before, you do a surgery. It's an expensive surgery. It takes a lot of commitment for the patients. What you want is long-term outcomes that are successful. You know, 5, 10 years later, the patients still keep their weight off. So what we're trying to do is use new technology to help keep people on track, to intervene before they gain the weight back. So with Robert Wood Johnson Physician Enterprise, we're trying to get more into telemedicine, use Wi-Fi scales so that the nurse in the office, the nutritionist in the office can find, track people. If they start gaining weight, call them up, have them come back to the office, find out what's going on, intervene before they gain weight back. Because you don't want to have somebody who's lost 150 pounds, start gaining weight back, and now they're up 100 pounds. They still lost 50 pounds, but now once you gain that 100, people tend to get depressed. You know, they've gone through a whole surgery, they've done really well, and now they haven't. So what's really important is using new technology. So telemedicine, being able to have the nutritionist just call the person up, talk to them over the phone, make that contact, make that intervention ahead of time. Understand, like, oh, you've been doing really well, why are you up 5 pounds? Oh, you went on vacation, okay, let's get the 5 pounds off. Let's not let it become 10 pounds, 15 pounds. And that's really unique to the Robert Wood system. No other system's doing that. The Physicians Enterprise is on board with that, and so that'll be something that will really be a huge benefit to our patients long term, because like you said, you really, with all the effort that's put in, you really want to have as many patients successful as you can.
And you want to have them successful for the rest of their lives, not just for 1 or 2 years.
Yeah.
You'd like to see in 5 years they've been able to maintain that weight loss, and down the road even 10 and further. You want to see that they maintain their blood pressures under good control with less medications if at all possible. Same thing with diabetes. If we can reduce the risk of diabetes or diabetic complications, hypertensive complications, we've really been very successful with the use of the bariatric surgery.
I mean, we all, in your practice and my practice, see people come back and they say, oh, I know this person who gained the weight back. I know this person who gained the weight back. So what you want to do is you want to do your best as part of our system to intervene and have the least number of patients gaining the weight back, getting their hypertension, diabetes to recur. The key is it takes a lot of resources, it takes a lot of effort. It's not a simple thing. That's why being with Robert Wood Johnson is important. They have a lot of resources to help us out. The ability, like we're trying to have more psychological, you talk about psychologists ahead of time. It's very important to have that support. That's hard in today's time. Mental health is probably the area of medicine that's not, I would say, like has the most resources it should. And with patients who have eating disorders, if you view people who get that heavy, I always view it as an eating disorder, they need not only the help from me, you, the nutritionist, they need help that if they have stressors in their life, they're dealing with them with a psychologist. That's been the hardest area to deal with patients, getting them to see psychologists more often. As you know, it's hard to get those resources. With Robert Wood, we're trying to do that. We're trying to hire psychologists in the office. Same thing, that every time the patient comes to the office, they not only see me, they see nutritionists, psychologists. So once again, having a more like team approach to the patients, hopefully we'll get better outcomes.
Well, the fact that Robert Wood Johnson has the team approach, is putting money, investing money in this, the fact that they're using the new technology in order to follow up, the fact that they provide a nurse coordinator who, but not only an RN, but has the master's degree in bariatric surgery. We're looking at the best educated people to be working with our people so that they are successful. And with success, we hope to reduce the risk of heart disease, diabetes complications, et cetera. And again, we have one of the best surgeons doing the bariatric surgery, so we're very proud of the fact of how good the outcomes will be in the future because of what you're doing.
I mean, the key is having an internist, family docs that work together with the specialists, and it helps patient care. So it's always that identifying the people at risk, have the issues, people will be good candidates, and then having them get into the right system.
Any last thoughts before we finish the show?
I just say that as Robert Wood Johnson gets more involved in long-term care of the patients, that's really exciting. I think they're also going to go to the payers, because that's a big thing, and go to those payers and show our outcomes, which want to once again help the patients with having things paid for. Because if you don't have the payers, the insurers on board with the big healthcare systems, makes it harder for patients to get access. And I think that that's a really exciting part of, like, when Barnabas and Robert Wood Johnson got together, you have more, let's say, power to get things for our patients.
And Sandra, any last thoughts?
I agree. I think it's an exciting journey, and I think it's a wonderful tool for people to help them on their road to good health.
Well, what I love is the fact, one, that you guys have improved the surgery tremendously. Two, that you have a team approach to this. I can't take care of the patients in my office by myself. You can't take care of the bariatric patients. And you've learned to expand that team to as much as possible. And the fact that Robert Wood Johnson is willing to put their money where their mouth is and do exactly what's best for the patients. And the fact is that we will reduce the metrics, we will improve the health care of the people, and the fact that this is all being done in a community hospital close by to people, so they don't have to travel hundreds of miles. They're seeing the best right here in this area.
Great, yeah, I agree.
Thank you for joining us today. This concludes today's episode of Robert Wood Johnson University Hospital's Health Talk. Please remember that the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral number at 1-888-724-7123. For more information about Robert Wood Johnson University Hospital, Somerset, please visit our website at www.rwjbh.org/Somerset. Thank you both for being here, and thank you for everything you do to improve our patients' care.